Hello, everyone. My name is Suzanne McGurn. I'm the President and Chief Executive Officer of the Canadian Agency for Drugs and Technology and Health, referred to as CADTH. It is my privilege to moderate today's webinar on remote monitoring for cardiac conditions that will review CADTH's evidence and then specifically dive into clinical and patient perspectives. I'd like to begin today's discussion with a territorial acknowledgement. CADTH recognizes the inherent and treaty rights of all First Nation, Inuit, and Métis people across this land. We acknowledge the harms and mistakes of the past and are committed to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. CADTH staff work across Canada, residing on various traditional lands and collaborating with Indigenous governments, healthcare providers, and community members. Our offices in Ottawa are located on the unceded and unsurrendered territory of the Anishinaabe Algonquin Nation. Our Toronto offices, where I happen to be located today, are on the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. Wherever you are today, I encourage you to think about where you live and work and to give thanks to the Indigenous people who lived there before you and who still live there and continue to sustain and protect the land that we call home. As we move into the discussion today, we're going to be moving through how the event will unfold and then introducing our speakers. So today I'm pleased to present that this is the first of two webinars sharing information about CADTH's work on remote monitoring for cardiac conditions. The expansion of digital health since the start of the pandemic has been nothing short of remarkable. As the uptake of technologies grows, so does the need for evidence to guide decisions about how, where, and when they can be used most effectively. In December 2021, CADTH published our Health Technology Review and Recommendations report on remote monitoring for patients with cardiac conditions. This was the first CADTH project to incorporate a Realist review into the health technology assessment, assessing specific context in which a certain intervention may or may not work. This type of review acknowledges the complexity of the healthcare system and the lives and people who interact in it. We're going to be sharing the recommendations that emerged from that report, as well as hearing from a clinical and a person with lived experience on implementing and using remote monitoring programs for cardiac conditions. A second webinar will be occurring 1 week from today, and it will have more of a policy focus with program administrators and those on the front line sharing what they've learned about implementing remote monitoring programs across Canadian jurisdictions. So today I have the distinct pleasure of introducing three presenters, and I'm sure you're going to enjoy hearing from all of them. The first off is Leslie Dunfield, who is our Vice President of Medical Devices and Clinical Interventions at CADTH. She's been with CADTH for over 10 years and oversees HTA, rapid response, and horizon scanning, in addition to working with expert and advisory committees. I'd also like to introduce Dr. Rupinder Sandhu, who is a cardiac electrophysiologist and an associate professor and director at the Smith Heart Institute at Cedars-Sinai Medical Center. And Dr. Sandhu is also an associate adjunct professor of medicine at the University of Alberta and a health technology expert review panel, HTERP, expert member. And last but certainly not least, Jim Lister became involved in 2018 as a patient partner with the Island Health Virtual Care Team. Jim lives in Comox, BC, and he has been living with heart failure since 2006 and enrolled in the home health monitoring since January 2020. So welcome, panelists, and thank you for joining us today. About the format, each of our speakers will speak for about 15 minutes. We'll take questions at the end, and you can submit your questions at any time using the Q&A button on the Zoom control. Please take a look at the slide to help you find that Q&A feature. and we will, and I will be able to use that to ask questions of our speakers. If your question is directed at any particular speaker, please include that in your comments so that we can get the right person to answer your question. And with that, I'd like to start by turning the presentation over to Leslie Dunfield to kick things off. Over to you, Leslie.
Thanks so much, Suzanne. And I hope everybody can see the presentation. Thank you. And so today I'm going to provide an overview of CADTH's work that we did on remote monitoring programs for cardiovascular conditions and why we conducted this work. And just a brief background, that CADTH is a non-for-profit organization that provides Canada's healthcare decision makers with evidence to support decisions about the appropriate use of drugs and devices. And so with remote monitoring programs, as you'll hear from our last speaker, they are well established in some of the jurisdictions across the country, but there are other jurisdictions where they're still considering exploring or implementing remote monitoring programs. And with these jurisdictions, the decision isn't about if remote monitoring should be offered, but the questions are around the implementation of remote monitoring programs and when and how that should be offered. And so this question was brought to CADTH as an alternative to supplement face-to-face healthcare. And with a geographically diverse country like Canada, where we've got the different settings with rural and remote and urban, it does allow for an alternative for those who live in rural or remote areas for healthcare. And this became increasingly important during the pandemic when virtual care was essential. And so for the work that CADTH conducted, we focused on the chronic cardiac conditions of heart failure, atrial fibrillation, hypertension, as well as cardiac rehabilitation. So a bit of an overview about what is remote monitoring. It's a type of telehealth where healthcare is delivered to patients outside of a traditional healthcare setting. And it's the exchange of health data between patients and providers using a method of telecommunication or devices. And the goal is really to promote that management of healthcare at home or in the community, helping to improve patient outcomes and potentially reduce health system use. And for the sake of the work that CADTH conducted, we considered programs that were formal and organized programs that were offered through a health authority or a healthcare organization using technology to collect and transmit data. And an example of this would be patients with hypertension, excuse me, where blood pressure readings would be transmitted to evaluate treatment effectiveness. And an important thing to note about the work that CADTH conducted was that it wasn't specific to an individual technology. We were looking at remote monitoring technologies and programs as a whole, not an individual specific technology. And so what did CADTH do? We produced a health technology assessment and a recommendations report on the work to support decision-making about the implementation of remote monitoring. And so if a jurisdiction is considering implementing a remote monitoring program, what do they need to consider to do this? And so what we did was a Realist review, a review of perspectives and experiences, and an ethics review. And as Suzanne mentioned in her introduction, the Realist review, this was a first for CADTH. This was the first time we conducted a Realist review. And a Realist review isn't focused on the clinical considerations or the cost effectiveness, but rather it's reviewing the conditions or the context by which a program would be effective, where it may or may not work. And so why will the intervention be successful under what circumstances? We also conducted a qualitative evidence synthesis about perspectives and experiences, and we included perspectives and experiences of patients, caregivers, informal caregivers, as well as providers. We also conducted an ethics review to look at the key ethical issues arising from the use of remote monitoring programs. And all of this information was used by the Health Technology Expert Review Panel, or HTERP, to develop recommendations. And you'll hear later that Dr. Sandhu was one of the clinical experts on that panel to develop those recommendations. And so with HTERP's recommendations, they looked at the evidence that CADTH provided to them. They found that overall, remote monitoring was found or perceived to be of use to and beneficial to health. It was found to be an attractive complement to existing services, so a complement to face-to-face care, but not an alternative to face-to-face care. There was the potential to reduce avoidable hospitalizations, but it may also increase workload and costs. And an important consideration is that of the evidence that CADTH did review for this, some of the targeted populations for this type of intervention were not found in the literature or were underrepresented in the literature. And so with the HTERP recommendations, the panel recommended that the design and implementation of remote monitoring programs would include a broad range of stakeholder voices with specific considerations across 5 domains. And I'm going to go through each of these domains now with those considerations. So the first one is patient and caregiver considerations, and remote monitoring programs should be flexible and adaptable to patient circumstances. And so remote monitoring technologies may be bulky, they may be intrusive, and so it really needs to be considered the patient's lifestyle and how that is going to fit within their lifestyle and their individual circumstances. So something like the size of the actual equipment and how easy it is to use. Something like battery life needs to be considered. How long are you going to be able to go with this technology? And so making sure that it was tailored to patient circumstances. There was also a need to ensure that the caregiver needs were addressed as well, because remote monitoring may increase the burden on caregivers, where they might be helping to monitor or helping with some of the technical components of the remote monitoring program. And the availability of technical support was highlighted as well to enable that, solving those problems for any technical glitches that may occur. And then considerations that the patient's voice needs to be heard in the selection and adoption of the specific remote monitoring technology. And the second domain were the provider considerations, and remote monitoring programs should be an integral part of the care pathway for chronic cardiovascular conditions. And so something like integrating it into a health process, integrating it into electronic health records, so that there is that smooth transition of information sharing, nothing is getting lost between providers. It was important to note that this may increase the workload of healthcare providers with an increase, a possible increase in administrative tasks. The number of patient contacts might go up. There might be the need for that rapid decision-making with interruptions, and so that is an important consideration as well. And the program costs for these remote monitoring programs. And so it's not just the cost of the technology, but cost of supporting the technology, as well as that remuneration for the providers. And with some of the patients perhaps receiving care across jurisdictions, across provinces, consideration for that cross-jurisdictional practice was important as well. The third component was the data and privacy consideration for the transparency about the information flow and the use of patient data, and the privacy should be at the forefront of contract negotiations. And so there was consideration about unclear risks and concerns about the future or current uses of the data, how the data might be transmitted, how it might be stored, how it might be transferred to other jurisdictions. And so really looking at the service contracts with providers to mitigate some of those concerns. Excuse me. The other consideration was around digital equity with remote monitoring programs, needing to avoid creating or exacerbating inequity in healthcare. And there could be limitations and barriers related to infrastructure for remote monitoring, something like a stable and reliable internet connection, but also even the devices or technology, if you're using your smartphone for some of these, which is an attractive alternative for some providers with the use of smartphones in a bring your own device model. But all patients may not have the same device, and there may be differences there and some barriers with that type of infrastructure. And so supplementing that with other considerations. And then the final domain was the evaluation. That remote monitoring program should include an evaluation component to ensure the program aims are met. And with remote monitoring programs, they may have different goals depending on the program and depending on the patients. And so being transparent about what are those aims and what are those goals, and is there a way to measure, and ensuring that you're measuring whether those aims are met. So quality of life may be what you're aiming to measure, but it might be also accessibility, improved communication, enhanced autonomy, keeping patients in the community. And so having a mechanism to ensure those goals are met with the program. And so with the work, after we completed the review and recommendations, there are a number of other tools that are posted on the CADTH website as well to help with decision making. There is an in-brief as well as a summary report and a policy brief that are also posted, and I'll include that link later on in the session. And these are other tools that can be accessed and used to support decision making. And I just wanted to highlight that in addition to the project team who helped with this work, we heard a lot from patients and providers, and the insights and the valuable contributions from a number of different stakeholders really helped to shape this work that CADTH conducted. And I will now pass it back over to Suzanne.
Thanks, Leslie. A great introduction, and the questions are starting already. So I think that bodes well for our conversation later. Next up, I'd like to introduce again Rupinder Sandhu, and so I'm going to turn it over to you at this point, Rupinder.
Great, thank you so much, Suzanne. And it was a pleasure to be part of the HTERP expert panel and to be here today to present a healthcare provider perspective on remote monitoring programs for cardiac conditions. As mentioned by Leslie, remote monitoring really relies on that use of telecommunication technology for the transmission of health data between patients and healthcare providers. And remote monitoring programs have the potential for such a positive impact for patients with chronic cardiac conditions. And this can occur through several mechanisms, including early detection and treatment of issues to reduce healthcare utilization and resources, and allowing patients the ability to maintain independence and promote self-management while remaining in their homes and communities. Remote monitoring is a healthcare delivery approach that's particularly appealing in Canada, given the considerable number of Canadians afflicted with chronic cardiac conditions, our large geographical landscape of Canada where these patients reside, and the concentration of healthcare institutions with specialist providers, which are typically concentrated in select urban locations. And there are many important stakeholder voices critical to the design and implementation of remote monitoring programs. And I'd like to spend the next few minutes to identify some considerations from a healthcare provider perspective for the major components of remote monitoring programs that Leslie introduced. So the first is implementation. Remote monitoring programs need integration of remote monitoring technologies into healthcare processes and into electronic medical records. This lack of integration in healthcare, both from an organizational and technical perspective, can present challenges for the healthcare provider. Remote monitoring changes the way healthcare providers work and how they consult. So there's increased telephone or non-face-to-face methods that requires appropriate infrastructure for operation. This is particularly relevant with the introduction of the electronic medical record. The lack of interoperability between remote monitoring systems and the electronic health records possess several challenges, for example, in terms of increasing workload by having to enter data in multiple health data systems, inability to access data critical to decision-making, duplication and redundancy of tests. And this issue can become even more pronounced with different healthcare professionals using various EMR systems. The second is expectations. So it's important that remote monitoring is seen as an adjunct to in-person care, not a substitute. So we want to ensure that remote monitoring doesn't foster a higher dependence and expectation level in patients around healthcare professional support. So this isn't necessarily 24/7 data monitoring by a healthcare professional. And the third is evaluation. So prior to implementation, remote monitoring programs should develop an evaluation component to ensure program aims are met. And there are some considerations on how to evaluate a remote monitoring program. So as Leslie mentioned, we need to choose the appropriate metric. And in order to do that, we need input from all the stakeholders. So the providers, administration, patients. So what is going to be your metric? Is it going to be to improve quality of life? Is it going to be access to care for those that have a challenging time getting in-person care? Is it burdens or is it costs associated with remote monitoring? And it's important to communicate with the patient what those metrics are. So for example, are we trying to reduce the number of reoccurrences of atrial fibrillation or exacerbations of heart failure that result in ED visits rather than curing the patient condition? Remote monitoring also provides a unique opportunity to benchmark care. So there are many clinical practice guideline quality indicators when it comes to chronic cardiac conditions that could be used to benchmark care, and could also be what is collected as part of the evaluation component. And finally, evaluation of remote monitoring programs need to assess costs. So whether it's IT, whether it's the actual technology or personnel, that's critical in assessing cost effectiveness. Fourth is workload. So remote monitoring programs have the potential to increase workload for healthcare providers, but also to reduce time. And this increase in workload is likely to go beyond just cardiac specialists and also impact primary care providers, nurses, allied healthcare professionals, and administrative assistants involved in supporting remote monitoring. So what are some of the aspects of remote monitoring that can increase workload? Well, remote monitoring programs may increase the number of patient contacts. And although this is an opportunity to reach more patients, there needs to be a balance in terms of volume. It can increase the data that's needed to be reviewed to prep for consultations, and more time may be spent on each consultation because of it. There's a need for rapid decision-making and responding to alerts, which can interrupt the typical workflow. Again, with all of this, increased administration tasks. And of course, the lack of integration with the EMR will increase the prep time for consultations and make challenges in terms of decision-making about management if all the information is not in one place. But remote monitoring also is an opportunity to, again, identify and intervene earlier to reduce acute care healthcare visits, so ED or hospitalizations, and to have patients more involved in their care. So they may be more apt to focus on certain questions about medications and symptoms had they not in terms of remote monitoring advantages. And then of course, remuneration. Maximizing the success of remote monitoring programs should consider remuneration related to the increase in workload. And I think it's an important way to incentivize implementation, and it's a way to demonstrate that work is valued. Then again, another potential barrier to remote monitoring programs is related to jurisdictions. So in jurisdictions where individuals access specialized cardiac care outside their province or territory of residence, there may be limits on cross-jurisdictional practice created by professional licensure and credentialing requirements. And it may also create challenges to accessing remote monitoring. And this is an important area for the development of policies. And with this, of course, is the consideration of how data is transmitted and stored and associated privacy and security. This needs to be carefully considered, especially relevant to healthcare providers who are trying to access data in a timely manner for decision-making. Remote monitoring programs have identified evidence gaps that require further investigation, particularly the effectiveness of remote monitoring programs in rural and or remote areas, racialized groups and Indigenous people and people of low socioeconomic status. And we definitely need more investigation on costs and cost effectiveness of remote monitoring programs, across chronic cardiac conditions. So to summarize, remote monitoring programs have the potential for providing considerable benefit, and critical to successful implementation is a careful consideration of remote programming design, including how integration will occur in the healthcare process, an understanding that remote monitoring is an adjunct and not a substitute, careful consideration of how remote monitoring may increase the workload, and if there is remuneration, policies around cross-jurisdictional care delivery and availability of data, and finally, the remote monitoring program that's implemented should establish strategies for clear evaluation, both for the patient and the patient's care team. Thank you.
Thank you very much, Dr. Sandhu. And now I'd like to turn it over to Jim, who's going to share his experience and his perspective, having had a lived, I guess I shouldn't put it in the past tense, living with this experience. Over to you, Jim.
Great, thank you. Let me just get this up. There we go. Thank you, Suzanne, for that introduction. I'd also like to begin by thanking the Island Health Virtual Care team, as you can tell from the slide, for creating this slide deck for me. And thank you to CADTH for this opportunity to be part of the panel and to share my story. I've been living, as mentioned, with a heart failure diagnosis for the past 16 years and have benefited the last 2 from remote patient monitoring. Our program's designed, I think, for 12 to 16 weeks, but things just kept happening that I stayed on the program. My diagnosis followed a heart attack I experienced on the squash court. Well, I was on a 2-minute off-court break waiting to complete a squash lesson, a lesson I never finished. As background, I'm an Anglican priest living in Comox, BC on Vancouver Island, where I'm semi-retired and providing pastoral care for the Anglican Church on Denman Island, just south of Comox. At the time of my MI, my family was young, a wife, preschooler, and twins in elementary school. That night, I think my wife was told I had a probably 25% chance of making it through the night. And then that was extended and a little bit longer. So anyways, that was 16 years ago, and my young family is that much older and now somewhat dispersed. I've had an ICD inserted and replaced during those intervening years with a second battery change scheduled for next week. I actually just had a call an hour ago from pre-op saying, making sure who I was for next week. I also discovered some truth about living with heart failure before remote monitoring, such as the importance of not taking some medications on an empty stomach. That's something I learned after fainting while leading an early morning church service. I've also benefited from several new medication therapies and have walked close to 16,000 kilometers over the years. One of the significant challenges I've encountered during those years, and it's talked about a little bit, has been isolation from significant services. During the early years, I was attended to by my local internists here in Comox. They were just down the street. More recently, I was referred to the Heart Function Clinic at Royal Jubilee Hospital in Victoria regarding some medication changes. And attending this clinic meant a 500-kilometer round trip. Also in the fall of 2006, about 6 months after my MI, an ICD was implanted, and we were advised that semi-annual trips to the pacemaker clinic at Royal Jubilee would be necessary. Then, due to a device recall, the number of trips was doubled, with alternating trips to the Campbell River pacemaker clinic, still 50 kilometers away. There was no remote monitoring at that time, though it was undoubtedly someone's vision. Still, since then, local telehealth facilities and now the ability to have remote appointments using BC Virtual Visit have been great additions to receiving care without the time and expense of travel. So what about remote monitoring? During one of my stints in the telemetry unit, my wife and I saw brochures about Island Health's home health monitoring program. We were intrigued by the pamphlet, but the presentation was quite low-key, almost passive. Now, I tend to be asymptomatic, and when asked, we were told that, well, I probably didn't need it, home health monitoring. It was almost perceived to be a bother. So we put aside that thought. The reality is that this is a powerful tool, mainly as it enables me to learn more about and manage my symptoms. It's also a powerful form of respite for my spouse and now young adult children. Having been part of home health monitoring for some time, I also believe the educational benefits of the program highlight the importance of having the right information at the right time and given in the right volume, you could say the level of intensity. The program provides education for a journey, which a life with, as Suzanne, as you just mentioned, heart failure indeed is. There are small digestible amounts of information provided in real time. In addition, remote monitoring adds another localized member to the care team. The monitoring nurse can provide less time-pressured support than the heart function clinic or my internist. Being in a more settled environment at home, or that they may catch something in my voice to give an essential tidbit of education. And these conversations may also require less effort for me to digest. Many patients often, or at least I know I do, often want to put their best face forward when attending heart function clinic appointments, to be a good patient. And besides, the people are busy. But the backstory might be that there's a lot going on, whether it's edema or shortness of breath that's not present at the clinic. And I'm perhaps more likely to be open over a telephone call. So while preparing for discharge following hospitalization for heart-related issues in late 2019, I asked the ICU nurse about registering in the Island Health Remote Patient Monitoring Program, or home health monitoring. By this point, I was pretty familiar with the program from my work on the virtual care team, but it seemed that the nurse wasn't. She had to inquire about it. I believe home health monitoring is presently more well-known and widespread, but this points out the challenge of ensuring that everyone throughout a medical system is aware of current programs and their effectiveness. Well, not too long after being registered, I was provided with an iPad with the app installed and Bluetooth-enabled blood pressure cuff, oximeter, and weight scale, all linked by the program to my Island Health EMR, which is also accessible to the local physicians, although it's can be a frustrating process for them, I understand. As a result of HHM, I've developed a pattern of paying attention to my symptoms and making appropriate decisions in managing activity levels and symptom-based adjustments to medications. I'm also becoming more aware of even small system fluctuations. Remote monitoring doesn't require a family practitioner to visit, either in person or by phone or virtually, for data is automatically entered each time. And each time I send in a report, the monitoring nurse would have a note of it. The process is relatively straightforward. I sign into the app where I'm asked how I'm feeling. I'm prompted to put on the cuff and blood pressure and pulse levels are checked, and then the oxygen levels, after which I'm asked a dozen or so heart function related questions, which has me thinking about each aspect of my health and if I want the monitoring nurse to call. One of the earlier challenges with this questions is the recorded voice. I found the questions monotonous and the voice added, it's a digital voice, and I found it just added an extra burden to completing the program interview. Eventually, I located the mute button, was able to process the questions at my speed and without the voice. Perhaps a person could record those questions. Amazingly, there have also been instances of data inconsistency. The blood pressure cuff and scale each register a static reading. That's straightforward. The oximeter, however, records dynamically and also takes time to stabilize its readings. And unfortunately, an early and incorrect reading may result if the iPad is ready and poised to receive data. In one case, the recorded reading was for my blood pressure or oximeter was 55%, when the correct reading only a few seconds later was 95%. And just last Friday, my pulse was recorded at 27. That was a little low. And so it was, again, as I say, a second later, it was up to 51, but the 27 is what got recorded. So this resulted in a call from a very concerned monitoring nurse. The quick situation was quickly clarified, and I've determined a workaround to avoid it, but still. As much of remote monitoring provides data to the EMR, it also gives me access to the data as well. Now, I also understand that this varies on different RPM systems. Some only allow you to see certain current readings, some are more historical. So I can review past entries on the iPad if I'm wondering about earlier or recent trends. I can also access educational resources. In addition, the monitoring nurse can send recent data to my specialist or my primary care physician after unusual activity and in advance of a scheduled appointment. And as I can say with the Island Health System and Cerner, that the primary physicians have access to that system at any time. If I have questions about my current situation or if issues arise that I'm unclear about, remote monitoring allows me to reach out to the monitoring nurse for more rapid response than trying to contact and then wait for an appointment with my specialist or with my primary care physician. Remote monitoring provides expanded pathways of communication within the patient-clinician team. Point-in-time education and support by the clinician when checking in is a powerful tool provided by remote monitoring. Specific information can be provided when it's most relevant. One potential improvement for these check-ins would be if they were visual. Then it'd be almost like a personal home visit. And I think that's something that's being developed here. In the early years of living with heart failure, I regularly had low blood pressure due to my early medication regime. It didn't affect my activity levels, but I sometimes missed the significance of slight changes or trends that the RPM clinician would likely note. In one instance, I had a particularly low blood pressure reading, and having the clinician call caused me to express curiosity in a support group. Another participant noted their blood pressure was lower after exercise, and that caused me to reassess my morning training regimen and the timing of checking blood pressure, and to adjust my routine to include a preliminary check. And this change helps me to avoid a potentially low blood pressure during exercise, the change initiated by the remote monitoring call. Remote monitoring is vital in assisting patients to become independently able to manage and improve their systems. This is true in cardiac care as well as other specialties such as COPD, palliative care, kidney function, hospital at home, and many more. I understand it was adapted significantly for use during COVID-19. It's also important to note that remote monitoring is not just the technology. A clinician is behind the technology, interacting with it and with me or any patient. Many specialists may see remote monitoring as primarily applicable only for symptomatic individuals in whatever area of care. So for cardiac heart failure, these would be people regularly in the yellow or red heart failure zones. Yet even asymptomatic people like myself find value in the information facilitated. I also recognize that I'm an intelligent person with several university degrees for whom technology isn't a challenge, and I have the bandwidth here. Many others in similar situations might not have the cognitive ability, skills, or resources to use remote monitoring independently and may need outside assistance, at least initially. So to close, we'd say remote monitoring may not be everyone's cup of tea, but I believe this presentation will attest, it's been a powerful tool for me and my family, and we're very grateful for it. Thank you for listening.
Thank you, Jim. And as a frequent moderator, I really appreciate everyone keeping to time so that we have an opportunity for some questions to be addressed. So I'm going to work through a few questions that have come in on the chat line, and in a couple of cases, I may combine the questions as they're along a similar theme. So maybe just to start with a technical clarification, Leslie, I'll direct this one to you. Do we include remote monitors for cardiac implantable devices in this work?
Thanks for the question. No, we actually did not include implantable devices for the work that CADTH conducted. There was existing work that was ongoing or already completed in the implantable cardiac devices space, and so it was not a consideration for the work, feeling that that was already covered in other work. Thank you.
Thanks, Leslie. This question I'm going to direct to both Dr. Sandhu and to Jim. And it's really questions about how our clients and patients prepared for this. So, the questions talk a little bit about there are additional considerations beyond bring your own device. Even with your own devices, there's other things that need to be considered, including security, some of the things that have been touched on, the networks and affordable data plan. And also, Jim, in your presentation, you talked about sort of having passively observed the flyer in the clinic. Are there things that you would comment on about preparing patients to use remote monitoring, about things that they should be alert to, sort of as you were ending your presentation on being ready and socialized to the idea of creating a successful experience on remote monitoring. So Dr. Rupinder, I'll go to you first about those additional considerations and perhaps how you think about them from your clinical perspective.
Yeah, that's a great question. And I think that Jim really alluded to this, that in order for a successful remote monitoring program, everybody who's part of that patient care team needs to be aware of the availability first of remote monitoring and the components of implementation. And I think the increased awareness and the education that occurs prior to implementation is really a key to success. And that's something where I think everybody in terms of the patient's care team needs to be involved and really make a concerted effort. And if they don't know, to at least be able to access the appropriate resources to provide that education. And absolutely, I mean, with the availability of so many different technologies, we have to consider how does individual technology that somebody has abide by the processes that are implemented in the healthcare system. How is the security addressed? So I think we shied away from really taking this remote monitoring review to look at individual technologies and broader programs, but it's definitely something that we're going to need to consider in the future.
Thanks, Dr. Sandhu. And Jim, over to you. Thoughts about, prepping patients to be successful?
Well, for me, one of the things that when I had my heart attack, I was airlifted to Victoria, but ended up in Vancouver. And then after a couple of weeks was discharged back to Comox Hospital and then discharged out of there. And there wasn't anything. I know that now that the home health, as part of discharge planning from heart care, home health monitoring is one of the first things that is talked about. So it's identified. In my case, this was an intervention after some a self referral to ED and then ICU. And I think I was early, and maybe just the process wasn't set up enough. When it went through social home care, and they arranged for Atelis technicians to come out with the equipment and showed me how to use it and provided it for me, and we've just moved from there. It was, and I had a binder that goes through all the various aspects of, much like the heart care booklet.
Thanks, Jim. Leslie, I'm going to direct this question to you, and if there are others that you think should weigh in on this conversation based on the work you've done, please feel free to pass the baton. The question is related to, in terms of additional costs or contacts, was it looked at overall? And, from the experience of the person asking the question, they're saying what they really saw was a shift of cost, that is decreased hospitalizations, lengths of stay, and more brief intermittent contacts in the community. So did that perspective play out in the work that was done?
Thanks. And the work that we did at CADTH, because we did the Realist review, we didn't focus on the clinical effectiveness or the cost effectiveness of the programs. And so we didn't specifically look at cost. Throughout the deliberations and through the conversations that we were having, it was thought that there might be an increased cost directly to those providers, and some of the considerations around the remuneration, as well as the cost of the program and support of the program. And so those were the factors that were brought into some of the deliberations and the conversations that we had. We didn't specifically look at the costs due to decreased hospitalizations, but ultimately that's the goal, is to keep people out of the hospital, keep people at home, and reduce some of those unnecessary hospitalizations. So I'm not sure if Dr. Sandhu has more of a direct insight from the clinician perspective.
Well, I think you're right, Leslie, that this is definitely an evidence gap when it comes to remote monitoring, and there's lots of things to consider, and it really depends on how are you measuring costs and over what period of time, and costs can be assessed in lots of ways, short term in terms of technology, IT setup, the physician or clinician workload, and that's, you know, over a longer period of time. But if you're assessing a decrease in ED visits and hospitalizations, I mean, that may take a little bit longer to see the results of a remote monitoring program. So it really depends on, right from the onset, what is that measure that you think is important? And it may not just be a measure that the provider thinks is important, but you want to consider both from an administrative standpoint and from the patient.
Thanks, Dr. Sandhu. And maybe I'll just direct this question back to you. It's sort of tied to the answer you just gave, but I think your clinical experience might be a helpful perspective. What is that? Is it also possible that remote monitoring can actually reduce administrative workloads in certain cases?
Well, I'm hoping it does. I think it depends on, you know, upfront, whenever there's a change into your workflow, it takes a little bit of time of adjustment and seeing how to integrate it. But I think if the process becomes more seamless, it definitely has the opportunity to decrease some of those administrative tasks. So I do think that there is that potential, and just with that early recognition that whenever there is change or new adoption of a system or technology, that there is a bit of a learning curve, and it may seem a little bit frustrating at first, but it can easily be integrated into you know, everybody's workflow to ease things.
Thank you. And Jim, I do just want to share that, you know, recognition of the powerful patient story that you shared. So that resonated with our audience, and I wanted to pass that compliment along to you. Leslie, there's a question about the term remote monitoring, and described as a small part, you know, and perhaps, you know, the term itself is evolving. It's a tool of larger virtual support and a toolkit wherein clinical programs can be changed to integrate. And I think, you know, Dr. Sandhu, you spoke about that in one of your first slides, integrating care along a patient's journey. And, you know, what comes out of that is 24/7 AI guidance, lots of self-management learning, such as Jim shared with us, and the data. Is there a way that CADTH work will be able to pivot to capture these larger opportunities?
Yeah, great question. And I think there's so much more that could be done in this space, and it's vast, and the technologies are so diverse. And when you're looking at virtual care, digital health, the actual technologies and the changes within those technologies and the actual application and the possible applications for these technologies. And so that's something that CADTH is looking at right now, about how can we assess all of these digital health technologies and how quickly they're changing, but also how they can be integrated. And like, I think we're never going to go back to full in-person visits like we saw before the pandemic for some cases. And so how can CADTH incorporate some of those learnings into the work that we're doing, and specifically with how we're doing HTA and the different types of information that we're looking at, the different types of data that we can incorporate, how we're looking at those different implementation considerations as well, and where it's not just about the clinical effectiveness in a lot of cases where, you know, face-to-face versus in-person care, it might not be about that. And so trying to look at the larger picture for digital health in general, which would incorporate all of those possibilities, and looking at artificial intelligence and how complex that could be with the system and health technology assessment. And so certainly looking at all of the work that we've done in the digital health space and how we can apply that to other technologies and other interventions and with other conditions. And we specifically looked at remote monitoring for cardiovascular conditions, but I think Jim noted that this is used in a number of other conditions and situations as well. And so I think there's a lot of opportunities here for CADTH to consider more of those technologies and more of those conditions, and that larger opportunity to assess this space.
I've noted time, so perhaps just a couple more questions. And so are there any recommendations on demonstrating how valuable subjective patient data is to a program such as remote monitoring? Leslie, Rupinder, and Jim, sort of, any recommendations on how to better capture that information about the data that comes from subjective input from patients? Maybe I'll start with you, Jim, and then I'll work my way back to Dr. Rupinder, to Dr. Sandhu and Leslie.
Well, I guess the key would be just hearing more stories, getting more people. I know when I've been, whether it's remote monitoring or I'm involved with patient voices, talking to people or friends that are in the hospital or other places, just what facilities are available. And what I recall a friend of mine going in for heart work. I said, well, check this out when you're finished. So
thanks. Dr. Sandhu?
I think that's such a great question. And I agree with Jim in terms of the value of stories. And perhaps that's done in a more formal or systematic way, such as focus groups with patients and having the frequency of getting to hear what the patient perspective is. And then it can also be in a more systematic method in terms of actually developing patient-related outcomes. So, after hearing the stories and getting a better understanding of what's important, is establishing outcome measures based on that, and surveying patients either before implementation, surveying them afterwards to see, are those things still important to them, or are there other things that may have come up?
And Leslie, any additional comments?
Yeah, maybe just stress that it is very important for us as an HTA organization to hear those stories and to incorporate that in the work that we do, because that's a perspective that we're not bringing as researchers. And even something like hearing the story about the digital voice and how annoying that might have been or monotonous. Those are important considerations, and it's probably something that's fairly easy to solve. And so, just hearing what those considerations are and how we can bring that into the recommendations. And it is one of the criteria of HTRP's deliberative framework. What are those patient perspectives? What are their experiences? And bringing that into the recommendation. And at times that weighs very heavily in the recommendations that we develop. How easy is it going to be to use? Is it not easy to use? What is the burden going to be? And so we've really got to incorporate that type of information. And we do have a very strong patient engagement team here at CADTH that reaches out and tries to get those stories for us that we can incorporate into the work that we do. And so we really appreciate anytime we do hear those stories, Jim.
Thank you all for your contribution to that answer. Another question that's been raised is we've been talking about an active engagement between the patient and the clinics. And just any early thinking about what value there might be of technology that could passively and continuously capture key patient vital information. It doesn't require the patient or individuals to routinely capture and report. And Jim, I'm going to start with you because I'm going to frame the question in what you highlighted in your presentation was the value of you also learning from the data. And so I'm just curious what your response might be to that sort of passive 24/7 monitoring.
Well, I was thinking about that two things. One, I have an iPad or an iPhone, and it has that automatically built within in the iHealth. I also understand that UHN, the University Health Network, has a program called Medley, which can be used independently, but also ties into Apple iPhones to do exactly that. And the the medley will actually even do your heart registering, heartbeat, and everything else. So that's available. I mean, you've got to have the technology to do it, but I think those are great. You know, partly I carry an iPhone with me all the time, so it's there.
And Dr. Sandu, any comment you would add to Jim's response?
I think it's really an exciting direction to have all the passive data available. The question is really, what do we do with it? You know, what is the next steps of care? So we see this a lot in terms of even rhythm monitoring. Jim mentioned the Apple Watch. Everybody has one. It can detect abnormal heart rhythm called atrial fibrillation. What do we do with it? So I think we really need to figure out how to use this data and if we have the appropriate resources to monitor. Because those are two very important aspects that need to be really ironed out before we encourage all this information to be transmitted.
Thanks for that. And with that, the last few questions we've been unable to get to, but I will just flag as I'm closing off, you know, a question that's asked, with all of the digital technologies on the horizon, how do we plan on reviewing them all at scale? And I think the answer is, we can't review them all at scale. And I think it's going to be a very, you know, a conversation about which ones do get selected and why, and then how. And, you know, there's not a magic answer at this moment, but I hope these conversations do help us inform future work and as well future choices that we make in looking at technologies. And with that, I'd like to bring today's session to a close. And I want to thank Leslie, Rupinder, and Jim for your insightful presentations and your willingness to take questions from the audience. I'd also like to thank Krista Bergquist and our events team, Peter Chinnick and Jose Nugent, who helped put today's event on. And for all of you who took time out of your busy day to listen to this conversation, it's great to have the opportunity to get the information out to people. And even if we can't get to all of the questions, to understand the type of questions that are being asked, that helps us do our work differently into the future. So thanks to everyone today, and I'm going to bring today's session to a close. Take care, everyone. Stay safe.
Thank you.